My name's John Marshall. I'm your moderator, and I'm going to head off this afternoon where we got a bunch of really smart folks after me who are going to talk about where we are in cancer medicine today. And I'm going to try to give you kind of an inside look as to where we are with things. So I think I just touched it. Maybe I did, maybe I didn't. Maybe I have to be near here. I don't know. It's very slow. Okay, so you've seen some of this slide before, but I wanted to make sure when we talk about precision medicine, I want you to understand what we're talking about. This is doing genetic testing or some sort of molecular testing on the tumor or on the patient to find out whether or not there's anything going on abnormally that we can use medicines for. And so we order these tests. We get results back. We're excited to see the result, a little bit like Willy Wonka opening a chocolate bar. Am I going to get a golden ticket or am I going to get nothing to work with? And there are different molecular abnormalities. When I first started 1,000 years ago, there was none of this. Okay, it was all one disease. And we treated them all the same because we didn't know any better. And the more we look, the more we are dividing and conquering into the different molecular subtypes so that we can understand how best to treat the patient in front of us. There's a lot of talk in the world today about guidelines, the NCCN guidelines. That sort of suggests it's not a rule. It's sort of the map. You should follow the map if you can, but you don't have to follow the map. No, you have to follow this map. This is beyond guidelines. This is, if you don't do this for your patient, you're deviating from the standard of care. Does anybody know a nastier way of saying that? That's called malpractice. That is a deviation from the standard of care. So if anybody in this room who has gastric cancer and doesn't know these answers, your physician, your team has deviated from the standard of care. All right, so you need to know, and everybody needs to know. There is no breast cancer patient who doesn't know her ER, PR, HER2 status. They all know, right? There's no lung cancer patient who doesn't know if they have a particular molecular abnormality. They all know, because their treatment varies dramatically by which one of these they are in their category. So we need that same culture. It's not an option. This is the standard of care. We're going to get into it. I pushed the wrong way. I'm going to pay the price for that. All right. So let's just look backwards about 10 years. I've been doing this a long time, so I get the benefit of looking backwards. Just about 10 years ago, now 15, the belief is that cancer was clonal. Everybody know what I mean by that? So clonal means that all the cells are the same. Think a field of grass, and all the blades of grass are the same. And so we just treated them all the same. But now we know, thanks to precision medicine, that it's not a field of grass, it's a forest. They're all trees, but there are pine trees, and there are elm trees, and there are oak trees. And some of our drugs kill oak trees, and some of our drugs kill pine trees, but it's a forest down there. So it's polyclonal, and our drugs have taught us that. 10 years ago, we said immune therapies were stupid. They will never work. I, of course, started my career in immune therapy research. I was laughed off the stage. I was trying to turn the immune system on with vaccines. That was what we were trying to do. It turns out it was already on. That was the mistake I made. What you needed to do, and what got a Nobel Prize, is figuring out that you needed to cut the brakes. You needed to open up the availability of the immune system for our patients. 10 years ago, we did a little gene testing here and there. Broad molecular profiling is the rule of the day for all patients. 10 years ago, the only way you got a drug approved is big randomized phase 3 clinical trials. Now, if you have the right drug for the right patient in the right setting, you can get FDA approval on single-arm studies, no placebo, no control arms, and getting approval. 10 years ago, the microbiome was just disgusting. It's poop, people. All right, so that's the bottom part of the river, but the river starts way up here, and it's covering all the way through our GI tracts. Do we believe in evolution? We're in Virginia, so some people might not. But if you believe in evolution, we evolved to keep this stuff inside of us. And we docs in the room spent approximately 2 hours of our 4 years in medical school learning about the microbiome. We memorized some bacterial names. We got them right on the test because we're smart, and then we promptly forgot them. And yet, the more and more we look at the role of the microbiome in our health, the more we think that not only is it part of our health, I think it's where the soul resides. I'm actually not joking about that. I think who evolved to hold who is really what we need to start thinking about. And the more and more we look at the microbiome, the more critical it becomes. 10 years ago, I said cancer treatments could not be more expensive. I was wrong. 10 years ago, oncologists loved our jobs. We were among the happiest of all healthcare providers. Currently, we have the highest burnout and suicide rate of all. It's a different world right now. And what we do is hard, and they're part of the team. And I'm here to represent that part of the team. So I'm going the wrong way again, hopefully. Then this little thing called the pandemic changed everything. But this is healthcare today in the United States. We have everything. We have fancy genetic testing. Surgeons don't even need to be in the same state as the patient. That's true. They tested it. You need to be in the same country. The lag between Europe and here is just long enough to make it not safe. But it's still a fraction of a second. It's a video game. It's a total video game for the surgeons nowadays. This is CAR T therapies. These are engineering immune cells to go and fight cancers. But unfortunately, this is also healthcare today, where I'm not looking at the patient. I'm looking at the chart over here, right? And so we need to figure out how to turn ourselves back so that we are with the patient in our world. So we have robots, we have all sorts of things, but we don't have enough people. We're losing trained professionals. There's going to be a shortage more and more. We're doing more and more of this kind of fancy stuff, IO therapies and cell therapies. We've lost control over research. The nice head of the NCI has some control over research, but that is incremental science. When she says foundational science, those grants that are at that 10% pay line are not asking very provocative questions. They're answering safe questions to get us one more step higher on knowledge, right? So what we need to figure out to do is how to leap some stairs, right? And that's different than we could not do it without the incremental science, but we have to leap. But the other piece is that with the industry, and we are all here together, they have a certain perspective on what they want to do. And they're investing a huge amount of money in research, but for their gain, right? Not necessarily for global gain. And so we need to get some of this control back. Now, that's Ho Chi Minh City. 1 in 7 people on our planet has access to the cancer care you all are receiving. 1 in 7. It doesn't take very far to go to where they don't have really much of anything. That's 40 people. That room turns twice. There are 3 nurses. There's no Metaport in that room, all right? And looks like to me they're all getting the same thing as far as I can tell. But nonetheless, versus business class, right, over here, where you get meals through the day, they serve you stuff, you get extra. You want a little more Zofran? How about some Ativan? We got a special today on Ativan. We'll throw a little of that in for you. So this is the difference around the world of what we're delivering in cancer care. So we have everything. We pay a lot for what we get, right? Cancer care teams are in cities. You can't get high-end, complex, multidisciplinary care in a town of 50,000. You can't get it the way it's delivered in cities. Our patients, you, treat us like employees. We're expected to answer that portal message by the end of the day. And you're wondering what we're doing and why we're not answering you and your question, okay? So we are expected to deliver. I'll go into this judgment of value when you talk about things you can talk about on the Hill tomorrow. We're monitored by insurance companies. We have people, I'll order a chest, abdomen, pelvis scan, and I'll get a thing back from the insurance company that says, we approve the chest and the pelvis, but not the abdomen. How many people are watching this? So I go like, fuck. What do you mean? I've got to do a peer-to-peer evaluation for some clerical error that somebody made. It's going to cost me about 20 minutes, me and my staff, about 20 minutes to get that abdomen approved, even though it's an appropriate test to do. Our economy is dependent on this system. It's a false economy, but we're dependent on it. And if you don't have insurance, we'll figure it out anyway. And then, of course, who's experienced one of these? There was actually an IV Ativan shortage right now. We have to decide who's going to get the IV Ativan in our infusion center. There was an oral 5-FU capecitabine shortage. There's been a leucovorin shortage, all sorts of stuff that's been around forever. All of a sudden, one plant somewhere, gets broken, and that drug was being only made by that plant. So we're starting to have shortages in the U.S. Here's the law of the land. This comes from Bush 2, the Medicare expansion law. And the deal was that if we're going to give Medicare coverage for drugs, here's going to be some new rules. First one is that the FDA can't see how much it's going to cost, and Medicare can't see what the magnitude of the benefit was. So if the FDA says, okay, it met a statistical endpoint, throws it over, CMS says, okay, 2 months of improved survival, I got to pay the bill. Right? So without being able to see magnitude of benefit compared to cost, we cannot judge value in this country by law. Okay, that's a law of the land right now. I'll show you where it's being challenged. It's not true everywhere. In Europe, in England, formerly known as Europe, briefly known as Europe, England has this, the public health service. Some love it there, some hate it, but nonetheless, everybody has health care. If it's FDA approved and you have money, you can have it. Okay? If it's FDA approved and you want the public health service to pay for it, and this committee called the NICE Committee, National Institutes of Clinical Excellence, reviews it, publishes it transparently in Lancet or Lancet Oncology, their review, because they've got to decide if we're going to bring a new drug in, the books have to balance. So I've either got to take it away from here or tax more. Those are my choices. So if they're going to make an expensive decision, they have to be transparent about it. And then the public health service pays for it or not, right? They are judging value in their system. And then you need to know this, is that lots of clinical trials are done in parts of the world that are never going to get that drug back, okay? Because they are dying to get on these trials. How did this happen? You want the best treatment. I want to give it to you. The guidelines, thank you NCCN, approves them quickly. I'm incentivized to give you more treatment. The more expensive the drug is, the more money I make. New developments come along. Media loves this stuff. Channel 4, NBC4 here is I'm always on NBC4, right? Because some new thing happened, we want to talk about it. It's a good story. It's a positive story. Value is not judged, and the wheel spins, right? And we believe it's free. We think it's coming from our insurance companies. Free, the government. Who's paying those people? You are. It's your money that's going into this wheel, that's feeding this wheel, all right? The middle class has not received a raise in a long time because of this, okay, in the United States. We got to deal with it. Now, so what I would challenge you to do, next time you say, I want one of those things, would you pay for it? Would you whip out your Visa and pay, I don't know, $30K a month for some of these drugs? It's a used Toyota Camry. You can't get a new Toyota Camry anywhere in the world, but a used Toyota Camry every month, would you pay for it if you could, right? It becomes a value judgment. And then there are people, that's us, who can afford to be here in Washington and go and advocate for ourselves. But what about those folks who are just trying to get by already? And they're the ones who find out that their appendicitis is not, in fact, appendicitis, right? And that all of a sudden their world's turned upside down. So I heard, everybody talking about the language. It's a whole new vocabulary you've got to learn. The time investment, if you're an hourly worker at Starbucks and you get this kind of disease and you need every other Thursday off to get your oxaliplatin, you got to make some decisions whether that's something I can do or not, right? And so, and then we've talked a lot about survivorship. Thank you, thank you, thank you. You can't do this by yourself. You need a team around you. Cancer care is complicated to give. It's complicated to receive, and you need help around you. The more education you have correlates with your outcome, right? So it's not even in that case. And then where you live, we talked a little bit about international, but of course rural. If you don't live near one of these cities that has a cancer center or multidisciplinary care, we know your outcome is less good. But let me drill down even further on this, just in the interest of time. How do we figure out how to manage which patient? If we could become more efficient with what we're doing, we could give the right patients the right treatment more efficiently and to be less disruptive. And that's what we really need to do. Standing where I am, if you go about 1-2 miles that way, you'll be at Georgetown Hospital. If you go about 4, 5, 6 miles that way, you'll be at MedStar Washington Hospital Center. These are both great hospitals, big, busy hospitals. They have all the multidisciplinary team they could need inside those hospitals. The survival of GI cancers is 1 year different at those two hospitals. Has nothing to do with the care being provided. It has to be how well can I receive it? How much can I advocate for myself to receive it? So we were just hearing about navigators. We recognize that without special navigation to look ahead for cycle 2, cycle 4, cycle 6, do you have somebody who can watch your kids, make sure your rent gets paid, this sort of thing? It takes a village. So we have lawyers who provide free care to combat things like getting your rent taken away. We have data extraction that's being provided to prove that what we're doing is good. We're partnering with an advocacy group in this program to try and intervene. My healthcare system's buying this position, an extra position, to navigate for these folks who are in trouble. And our Ralph Lauren Center, originally a breast cancer-focused center, right, is out there. They know what our community resources are and what are available so they can connect the dots. This is what I think it's going to take to level that playing field of access. And we got to decide if this is something we care about when you go up on the hill. Is it really that kind of care for everyone? I want you to do a real big gut check right now. Is it really the care for everyone that you're after? We all have this slide. Or is it you? Okay? I want to be cured. That's a really important point to say. And so with that, that's going to be research and high end and making sure we can do it for those who can versus some for everybody. These are two very different perspectives. And I think in your heart and your soul, in your own microbiome, you need to decide which one of those it is, okay, that you're out there to do for others. Now, right patient, right target, right drug, you can get FDA approval. We'll have someone confirm or deny that later to see if I'm too much out there. But this is where we're going. If we're going to cure GI cancers, this is mostly focused on stage 4 cancers, okay? So we have to figure out how to make our immune systems work better. They're already working. They're not broken. But how is the cancer hidden from the immune system? How do we open it back up so that they can see it? That's going to be one major way of going. Understanding the cell signaling, and this is back to the precision medicine piece of this, new therapies, how to manage if you have one metastasis, if you have peritoneal disease, right? How do you manage that? We've already talked about AI and big data. The clinical trial speed has to increase dramatically. So here's the standard testing today for esophageal stomach cancers. And those are the tests you'll know about. You all know this drug? Do you know why you don't have it yet? It was FDA approved at the end of December, and you don't have it yet on the market because of some sort of manufacturing question. So we've been measuring this Claudin 18.2, but we haven't gotten the drug in our hands yet. And then there are a bunch of targets that are for any kind of cancer if they have that abnormality. What we really need is one of these. Everybody know what this is? This is a Harry Potter sorting hat. We need to go in as a doc. I need to knock on the door, go into the room, put this on, and say you had your surgery or not, and maybe you're already cured. Maybe you don't need any chemotherapy. You're good. You're good to go. Or you're not good to go, but I need to give you some chemotherapy. Or even if I give you chemotherapy, your cancer is going to come back. This is the categories that everybody faces once they think they've been cured of their cancer by surgery, for example. Instead, what I do now, I give all of these people chemo. I give them all oxaliplatin because I don't know better. When in fact, probably only 5% of people really need the oxaliplatin. Most of the people are benefiting from the 5-FU. Okay, so I give everybody that when in fact these people don't need it at all, and that's not going to work for these people. But I just give it and see what happens, right? So what I need is a Harry Potter sorting hat. And this is minimal residual disease test by a company called Natera. And essentially, it's a blood test that looks for DNA from patients, from the tumor. And if you're negative, your outcome's very good. And in fact, getting adjuvant chemotherapy doesn't change your outcome. If you were negative, you don't need it. Not going to change things. If you are positive, you're in trouble. You have cells somewhere, and if I just watch, your curve's crummy. If I give you chemo, I cure some people, right? So I'm finding the right patient for the right drug, even in the adjuvant setting. This is a study that we have open at Georgetown, where if you find yourself positive for ctDNA, and yet no evidence of disease on your scan, we actually are trying to bring in some immunotherapy to see if we can wake the immune system up to kill the microscopic cancer as a pilot study. So these are cropping up all over the country. If I do gene testing, DNA testing on these two critters, I get exactly the same result. Their next-gen sequences are identical because they're actually clones of one another. Now, this cute pink one lives in a lab and has a controlled diet. This one has been in the wild for 4 months, eating dirt, probably a different microbiome. We call this post-translational modification. But if I did a DNA test, it's going to be the same. Which cancer would you rather have? Cute pink one. Feels better, right? So I sometimes can't tell the difference between which one of these you have because my DNA test is going to look the same, okay? So we know we're getting beyond DNA into proteins and phosphoproteins. Remember, the DNA is the blueprint. The proteins and the phosphoproteins are the walls that actually go up, right? I thought that was glass. Turns out not so much, right? And so measuring this then requires a higher level of quality in order to make sure you get it right. So we're going to need help because we're now talking about terabytes of data on any individual. And we can't see it. We can't see the pattern, right? So we're going to need help to help us identify what's wrong, what are the patterns, so that we can say you need treatment and this treatment or not. Today, we are what I call in our awkward adolescence of precision medicine. We have the parts, but we're not quite sure where to put them just yet, right? And so we're learning, and I think AI will be one of those secrets. Everyone has been dancing around this concept of microbiome. We don't even know how to measure it. There is no button in my electronic medical record that says, do a microbiome test. There's not one. I don't even know, And where do you sample it from? Because it's different up here than it is up here than it is down here. In fact, you can even look at the colon now. This is, I realize, not our main topic, but it's at least 2 organs, a right side and a left side. And I think it's shaped that way to try to keep the 2 microbiomes apart because they're doing different things in the body. So the more we look, the more we're learning about this. But I think there'll be answers there. All right. We hate our medical records. You just welcome to my world, right? So the reason my computer's open right there is so I can make sure I'm up to speed and all of that through the day. It never goes away. It was built for billing. It was not built for information. Okay, so it's not really that smart. And so we spend a lot of time looking for your results. So precision medicine tests are the worst because they don't come over. If I order a CBC or a chemistry panel, it comes over into a nice, neat box. I can tell you where it's going to be. But if I order a Natera test or a Caris test or a Tempest test or a Garden test, who knows? It could have come faxed in and then somebody scanned it in under lab, could have sent it in under outside records. So here I am going, no, no. And then, 30 pages of outside record. Oh, there it is. So we have to then translate this back to our visible part of the electronic medical record so we know what was done. So as a patient advocate, one of the first messages you really take out there is know your own profile. Demand that you know, record it, keep track of it, because that'll help you in the long run. All right. This is going on right now, one of my last slides, maybe my last slide, in the United States. And this is pushing back on value. These were the first 10 drugs, I think I got it right, that were lobbed over to say we want to negotiate price on these 10 drugs. So not just all cancers, mostly non-cancer drugs, but there's some cancer drugs. And so this has caused a huge thing going on because nobody, only the US government and some payers want to do that. Patients don't understand why this would benefit them yet. So there's a lot of back and forth on this. So I know Maryland just held their first review of this last week, but this is going on there. But we will get smarter. As we get smarter, the value goes up because I'll know more it works. I'll be sure it works. There'll be less guesswork around it. We'll have longer survival, but they're going to have more and more subgroups. So it's not going to be stomach cancer. It's going to be HER2 positive stomach cancer and MSI high stomach cancer. They're going to be different groups, each one. We're going to have to learn to play together, but it'll be more and more subgroups, more AI, and ultimately, I think the business model has to change.